So my discussion today will be on cardiac MRI and in the use of cardiomyopathy. And again, we know that cardiac MRI is not something that is widely used, but still has a very important role in the evaluation of cardiomyopathy and is becoming even more and more important in the evaluation. Now, with my talks, I don't have any um, specific disclosures. When we talk about the main objectives for this talk, it will be to, one, recognize some of the pathways of myocardial injury and development of myocardial fibrosis. We are going to summarize some of the parametric MRI techniques that have been developed and that allow us to use to characterize myocardial tissue abnormalities. And then we want to see how we can differentiate different cardiac pathologies that can be evaluated using the tissue characterization techniques of MRI. Now, when we consider the use of MRI, and for all types of myocardial disease, including cardiomyopathy, the main thing is we want to understand the underlying pathology. With those pathologic changes, we think about what are the imaging correlates. How do we use imaging to see those changes in the pathology of the heart? And from there, we want to correlate to specific diseases. So having kind of a radiology and pathology correlation becomes very important as we also use MRI in the evaluation of different cardiomyopathies. So to focus first on the pathology itself. Now, when we consider pathology, we want to look at the histopathology of the myocardium. Now, what do I mean by that? Well, the myocardium can be divided into three main compartments. There is the intracellular compartment. This is where all the myocytes, fibroblasts, smooth muscle cells that make up the myocardium all lie in this compartment. Then there are two other compartments. One is an intravascular compartment, which is the blood pool. And then there is an interstitial compartment. The interstitial compartment is the residual space once you remove the intracellular and intravascular components. Now, the intravascular and interstitial components both make up what is called the extracellular volume. So you have your normal myocytes, and then everything aside from that is extracellular volume. So again, extracellular volume makes up the interstitial space and intravascular compartment. Now, this extracellular volume is relatively fixed. And in the setting of myocyte injury, your intravascular compartment is usually fixed. So any increase in your extracellular volume is usually due to increase in the interstitial space. And why do we have expansion of the interstitial space? Is because you have some type of myocyte injury and myocyte death. So those two abnormalities will lead to expansion of the extracellular volume. And there are two ways that we typically see this type of myocyte injury. One is called replacement fibrosis, and the other one is called interstitial fibrosis. And both of these are pathologies that we see in the setting of a cardiomyopathy. So first, talking about replacement fibrosis. This is where you have an acute injury to the myocardium. In this case, we can imagine due to infarction. So we have occlusion of the coronary leading to ischemia and infarct of the myocytes. So with that, we have edema, we get swelling of the myocytes, and then we have abnormalities of the intracellular function. Because of that, myofibroblasts will start to proliferate. These cells will atrophy, and then we get collagen, which lays down in this space, in this extracellular space, as a result of the initial injury. Over time, there becomes retraction of the space, leading to, again, expansion of the interstitial compartment and then expansion of the extracellular volume. So as a result of replacement fibrosis, we get expansion of the interstitial space and we get decreased myocardial mass because we've lost actual myocardial tissue. So as you look at the specimen on the right, we see that there is deposition of collagen and loss of mass in that particular area of the myocardium, and subsequent remodeling of the ventricle as a result of that. And this is probably the number one way that we see manifestation of myocardial injury, this replacement fibrosis. Now, in addition to this, we can also have an interstitial fibrosis. Now, as opposed to replacement fibrosis, which tends to be more macroscopic as a result of an acute injury, Interstitial fibrosis tends to be more microscopic and again can be seen in the setting of cardiomyopathies. So here there is a direct activation of myofibroblasts due to whether it's related things or something else. And then because of that, a reactive fibrosis occurs. So myofibroblasts get activated and they get set down. That leads to initially increased myocardial mass because you have normal myocardial mass, deposition of these fibroblasts, deposition of collagen, and that leads to increased myocardial mass. Over time, then you get a more of a reaction fibrosis. You get continued cellular activation, continued interstitial fibrosis, and eventually you'll have myocyte loss. Now, very early in the stage, this is actually potentially reversible. So you can identify the reason for the interstitial activation. You can reverse the injury. However, over time, if you cannot, then you have the reactive fibrosis that occurs that's leading to, again, myocyte death, expansion of extracellular volume and collagen, and subsequently loss of myocyte mass. And at this point, this is an irreversible change that we see. So again, these are the two main forms of injury we see to the heart in the setting of cardiomyopathy, both a replacement fibrosis and an interstitial fibrosis. So based on that, what are the imaging techniques we can use to identify this injury? So essentially, we want to characterize the tissue to understand the underlying process. And there are a variety of different ways that we try to characterize the tissue using MRI. Primarily, we use gadolinium-based tools. So we look at the perfusion of the myocardium and we look at enhancement. There are parametric tools. These are newer tools where we look at how the myocytes relax in different parameters, T1, T2, T2 star, and based on its characteristics, give us an understanding of the underlying myocardial tissue. And then finally, we look for evidence of edema or inflammation, again, sites of kind of acute abnormalities. So our gadolinium-based techniques help us look for more macroscopic disease, so deposition disease, myocardial infarct, all of them are signs of a replacement fibrosis. The parametric mapping techniques, again, this allows us to look for more microscopic disease. So disease where we don't see definite areas of enhancement, but we see evidence to suggest expanded extracellular volume and subsequently interstitial fibrosis. And then finally, again, looking for evidence of edema using a variety of different techniques. Finding edema in the myocardium suggests that you have active inflammation, and again, suggests that you have an active process. Now, when we talk about our gadolinium techniques, so again, this is the most common way that we look at the myocardium with MRI. Gadolinium distributes into the extracellular space. Gadolinium is not an intracellular agent. So when we give gadolinium intravenously, gadolinium is going to diffuse into the interstitial spaces in between the different myocytes. Now, in situations where you have some type of myocyte injury, where the myocyte cell membrane is disrupted, well, then now you have an increased percentage, increased concentration of gadolinium. And because of that, now we'll see increased enhancement, increased relaxivity on MRI. So again, the presence of myocyte abnormalities lets us see the more gadolinium in that space. And the first way we can see that is using first pass perfusion. So again, areas where the myocytes are not taking up gadolinium suggest that you have some type of ischemic injury. So in this case, we see here on the bottom right, so areas where there's decreased perfusion are dark, whereas the rest of the myocardium is somewhat brighter because gadolinium is permeating there. So essentially, underperfused area will have decreased gadolinium enhancement and appear as dark. And we can actually quantify the changes that we see here. So in this case, we see in red a region of interest in the blood pool, and outlined in green is the myocardium. If we look at the signal in those two regions of interest over time, we can see that there is an abrupt rise in the signal in the blood pool compared to a slower rise in the signal in the myocardium. And again, we can look at that in different territories so that we can see whether or not there are regional abnormalities. So in this particular case, this is a 58-year-old who had an abnormal stress test. We can see that involving the inferolateral aspect of the left ventricle, we see that there is an area of decreased signal. So there's hypoperfusion in this inferolateral segment. If you compare that to the kind of anteroseptal segments, which look nice and homogeneously enhancement, we can see clearly that there's an area of decreased signal. And by measuring that, as we see here on the bullseye plot and the graph, we see that the signal in the anterior and septal portions of the myocardium are much higher than in the inferolateral segments. So again, we can use this to quantify the severity of the abnormal perfusion. Now, with that, this is again some more images, again showing that the area of decreased perfusion. And when we look at the later contrast kinetics of gadolinium, we can see that there is also delayed enhancement in the same territory. So this tells us that this is more than ischemia. This is true infarction with death of the myocytes. And this also highlights the other strength of using gadolinium. The use of late gadolinium enhancement is really our gold standard for understanding myocyte fibrosis in both ischemic and non-ischemic cardiomyopathies. And essentially, particularly in the setting of myocardial infarction, we see the definite area of involvement, which corresponds to, again, myocyte death, replacement fibrosis, and deposition of collagen. Now, interestingly, in patients who have diffuse infiltrative cardiomyopathies, you may not have a focal area of late enhancement. Again, the interstitial process is very microscopic, and this is where the other techniques come to help us. Here, this is just another patient. This is a patient who came in presenting with underlying arrhythmias and ventricular tachycardia storm. We can see areas of late enhancement, again, involving infraseptal portions of the myocardium, largely epicardial in distribution. We see also evidence involving the infralateral aspect. This was actually someone who had acute sarcoidosis and extensive enhancement as related to the inflammation in that acute setting. Now, parametric mapping, this is a newer technique that we use with MRI, and this allows us to better characterize the presence of abnormalities. Again, we can identify microscopic interstitial fibrosis where you may not have focal areas of late enhancement. Now, we call it parametric mapping because essentially we are mapping different MRI parameters. So there's T1 mapping, T2 mapping, as well as T2 star mapping. And each one of these particular sequences help us identify certain characteristics of the myocardial tissue. So essentially we do multiple sequences over time, and we map the change in the myocardium over time to get a better understanding of the underlying physiology. So for instance, with T1 mapping, areas of abnormal T1 will relax much quicker than the rest of the myocardium, as opposed to T2 mapping. Areas of edema will also have longer areas of relaxation compared to normal myocardium. So again, the different techniques. So T1 mapping, this is also called native T1 mapping. So this is done before we give gadolinium, and this tells us the underlying, essentially the native abnormality or the native distribution of the extracellular volume in the myocardium. So on the bottom, we have two cases. This is a normal case, and we can see when we look at the late enhancement, we see that there's homogeneous signal, no evidence of significant late enhancement. On the right in color, this is the native T1 signal. And this is pre-contrast, but also looks very homogeneous. So again, we see that the native T1 mapping, pre-contrast, matches up very well with the late gadolinium enhancement. Similarly, on the right, we have this case of hypertrophic cardiomyopathy. we see with the delayed enhancement, we see multiple areas of delayed enhancement. When we look at the native T1, so again, this is pre-gadolinium, we can also see that it's not homogeneously involved. We can see areas of abnormality. So again, highlighting that even that there are underlying native abnormalities that we can see even without contrast. Now, certainly, using contrast allows us to see much more of the abnormality, but we can see this basic abnormality even without contrast. Now, normal native T1 values range between 950 to basically less than 1100 milliseconds. So when we see an area of native T1 that is above 1100, that suggests that there is an abnormality in that area and that you have expanded extracellular volume. And with that, the pre-contrast and we take the post-contrast, when we look at the ratio of those two sequences, we can actually calculate the extracellular volume. Now, I'm not asking you to memorize the equation below, but this is how we derive the extracellular volume. We look at the change in signal pre-contrast, compare that to the change in signal post-contrast. We look at the blood pool versus the myocardium, and that allows us to calculate the extracellular volume. And generally speaking, when you remember, our myocytes the heart is made up of 3 compartments: intracellular, intravascular, and interstitial. The interstitial and intravascular make up our extracellular volume. That should be no more than 30% of the total myocardium volume. If you have an extracellular volume of greater than 30%, then that suggests that you have some atrophy of myocardial tissue. You have expansion of your extracellular volume for it to be that high. And that suggests that you have an underlying cardiomyopathy, replacement fibrosis. Here are just a couple of examples. Again, this is the case of hypertrophic cardiomyopathy, looking at the late enhancement. And on the right, we're looking at the native T1 and the post-contrast T2, again, showing abnormalities. Both of these together help us to calculate the extracellular volume. Now, so that is T1 characteristics. When we talk about in the setting of iron deposition, iron overload. So we look at a form of T2 characteristics, particularly we look at what's called T2 star. And T2 star is a parameter that is closely associated with the magnetic field of the MRI. And the more iron that occurs within the magnetic field, the greater decay you have of your T2 star curve. And you can think of it like the spinning of a top. If you have a top that's spinning on a nice sheet of glass, well, it'll spin for a very long time. But if you have irregularity in the glass, well, then all of those interactions will make the top slow down much quicker. And that's what we see in the setting of iron overload. So T2 star value less than 20 milliseconds is considered for iron overload cardiomyopathy. Now, to look at that in a different way, so again, T2 star is related to T2. And again, T2 star relates to the inhomogeneity of the magnetic field. When you have iron, it makes that relaxation curve even lower. So again, when we see T2 star values less than 20 milliseconds, again, that suggests that you have significant iron deposition. So here's an example. We're looking at a portion of the heart. We're looking at 2 segments. We're looking at near the septum and more lateral aspects. Again, for any parametric mapping technique, we do multiple images over time. And here we see the curves for both of those times. And we see the curve for this lateral aspect of the heart is very low, suggesting that you have a focal area of iron deposition. In patient B, we see that there is almost diffuse abnormality of the myocardium. As we see here, this is someone with severe iron overload. So we looked at T1, we looked at T2, T2 star, and as far as parametric techniques, edema is probably the other important parameter that we want to evaluate when we want to consider myocardial injury and its relationship to underlying cardiomyopathies. Now, myocardial edema, just generally, we know that we have usually an acute peak that occurs at the time of the insult, and then later on, as we have fibrosis and retraction, myocyte cell death, then we have almost a second peak, a second phase of edema as we have increase in our extracellular volume. Now, myocyte edema occurs, again, largely in the intracellular compartment. And just to summarize, we have what's called free and bound water. Now, when we talk about bound water, it's surrounded by proteins that help give the cells its oncotic pressure. Now, when you have injury to the myocardium, what happens is that the number of bound water gets released and changes the oncotic pressure of the cell, leading to increased swelling and subsequent edema within the cell itself. Here's just an example. Now here we're looking at this is a patient that presented with chest pain, had elevated troponins. Now when we look at this is a T2 sequence, and when we look grossly, we don't see a significant amount of increased enhancement. Maybe there's some involvement here, but we can also see that maybe there's some artifact. So is this real or abnormal? If we actually do measurements of the signal, we can see that there definitely is increased signal in this particular area. So there is a suggestion that there is increased T2 signal in this portion of the myocardium. In addition to looking at just the heart, we can actually compare it to another tissue. So here we have a ratio. We are comparing the signal in the myocardium to another muscle, to skeletal muscle. And again, we see that there is significant increased signal in the myocardium. So this also corresponds with increased T2 signal, which means increased edema in this particular patient who has underlying myocarditis. And when we see the late enhancement, we can see the classic appearance for myocarditis. We see this epicardial enhancement. Incidentally, there's also a small pericardial effusion as well as some pericardial enhancement as well. Now, so looking for edema using T2 is very important, but as you can see, it was a little difficult early on. Using other techniques, including looking at the T2 ratio, helps us look for edema. But probably even more so, as we talked about before, we can also use parametric mapping techniques. So in this particular case, we did T2 mapping in the same area, and the classic value is usually less than 55 milliseconds at 1.5 Tesla. Greater than that suggests that you have increased edema in that area. And certainly enough, when we do evaluation of those lateral segments, we can see that the values are in fact elevated, consistent with edema. So, we talked about a number of different things. We talked about the type of injury that we can see with the myocardium. We talked about the ways that we can characterize that injury using the different techniques, gadolinium-based, using parametric mapping, and then certainly looking for edema. So now, how do we correlate that with actual injury, with actual, pathology? And, when we look at these abnormalities, we can get almost phenotypes of myocardial injury. So what do I mean by that? So abnormalities which cause replacement fibrosis. So when we think about chronic renal disease, it usually causes a diffuse fibrosis that, again, we should see as enhancement. Toxic cardiomyopathies, alcohol, chemotherapy, again, tend to cause kind of a diffuse area of replacement fibrosis, where localized fibrosis, so localized scar, localized infarct, we can see that in the setting of, again, myocardial infarction, myocarditis, hypertrophic cardiomyopathy, or even sarcoid. Now, interstitial fibrosis, so this is where we have, again, kind of inflammation, activation, and may not have focal abnormalities. Certainly amyloidosis tends to be more of a diffuse interstitial process. We have other disorders such as what's called Anderson-Fabry disease, which is, it's a genetically linked disorder, hemosiderosis, and we can even have just reactive interstitial fibrosis as hypertension, diabetes. You can have an interstitial fibrosis, even aging. As we get older, we get mild interstitial fibrosis, and certainly in the setting of certain dilated cardiomyopathies. So, and with that, we almost get like a spectrum of different changes. We know that with different disorders, we'll see different patterns of enhancement when we look at the native T1, when we look at late enhancement, and certainly when we consider the amount of expansion of extracellular volume. And again, when we look at this, we can see these patterns, and those all help us to determine the type of abnormality. Certain ones associated with more significant increase in T1 values, certain ones with expansion of extracellular volume. Of note, interestingly enough, amyloidosis tends to cause a very significant increase in T1 value and significant expansion of extracellular volume. Whereas a disorder like Anderson-Fabre's disease, we actually see decreased native T1 compared to normal and relative no significant change in extracellular volume. But to focus more on specific cases, here we're looking at a patient that presents with atypical chest pain. When we look at the steady state free precession images, we're looking at T1 values, both pre and post contrast, and the post contrast is done almost immediately after we've given the contrast, and we don't really see any significant enhancement. Again, you can compare the myocardium compared to skeletal muscle to see if there's any specific enhancement. When we look at T2, well, I mean, no real area of significant abnormality. This is fat that we see. Maybe you can say that there's a little bit of thing, but it's very questionable. Same thing on this particular technique. This is what's called a spare. This is also a T2 weighted sequence. So with this, we're characterizing the myocardium with multiple techniques, but not really seeing any changes. However, when we use our more advanced parametric techniques, we can see that native T1 values, I don't have the values here, but we can see that this area is somewhat brighter. And when we look at the extracellular volume, we can see that there is, again, areas of abnormality that we can see here on both visually and on this bullseye plot. So remember, we said that an extracellular volume greater than 30% suggests abnormality. So we clearly see that there is abnormality in this case, and this was actually another patient that had myocarditis. Here's another person that presents with new ventricular tachycardia. Same thing again. We see on the patient had a CT. We see significant mediastinal lymphadenopathy. We see that there is evidence of fibrosis within the in the lung parenchyma as well. Using these parametric techniques, we can see that there isn't a significant area of focal late enhancement, but clearly when we look at these parametric techniques, we can these are all elevated, suggesting that there is this increased amount of again, extracellular volume, suggesting that this person has underlying cardiac sarcoidosis, as we have in this particular case. So again, we use MR to evaluate multiple different parameters to help us put together with the clinical picture what the underlying problem is. Now here's a patient. This is a patient who has a history of sickle cell anemia. So what do we see here? So these are multiple gradient echo sequences. We're taking at the same slice location, but difference over time. Now, just even without doing any type of quantification, what can we see? Well, if we look at the liver and spleen, we can see that they rapidly lose signal over time, suggesting obviously that because of iron content. So there's definitely some evidence of hemosiderosis. But when we look at the heart, we can see that the signal does not really change. So this, even visually, this gives us strong confirmation that there certainly is evidence of iron deposition, but there's no clear evidence of cardiac involvement. So in this particular case, there is no evidence of significant cardiac hemosiderosis. Now, and again, this is the same case when we do the actual mapping. So here we're comparing liver, the heart, and then also skeletal muscle. And again, when we look at these different curves, so we see the liver, again, a striking curve because of the amount of iron composition, which we saw in the previous image. Again, it changes rapidly, versus when we look at skeletal muscle and the heart, we see that their curves are much different. In this case, a T2 star value of almost 30 milliseconds. Remember, less than 20 is considered abnormal. So this is someone who has, again, no evidence of significant iron overload. Now, just to compare, this is a patient who has a history of thalassemia. And again, not only do we see a very dark liver, it looks very cirrhotic in its contour. And again, when we look at the curves, so again, in blue is skeletal muscle, in green is the myocardium, which is vastly decreased compared to skeletal muscle. And when we look at the liver, I mean, the curve is practically flat. So in this particular case, the myocardium had a T2 star value of 12, which again suggests significant iron deposition within the heart. Here's another patient. This is a patient who have a history of multiple myeloma. On the left, we see abnormalities from late enhancement. And then on the right, we're looking at extracellular volume. And what's interesting, so we see that there is this subendocardial enhancement. Although the entire myocardium itself is relatively abnormal. Probably one of the hallmark features is that there is a difficulty in nulling the myocardium in this particular case, in this patient with multiple myeloma. So this is a case of amyloidosis, and amyloidosis can present with diffuse enhancement, again with abnormalities of nulling. There's also the subendocardial component, where we can see, again, enhancement here, but again, the myocardium is diffusely enlarged and diffusely thickened and abnormal. And when we look at the parametric mapping, again, we see a majority of the myocardium has expanded extracellular volume consistent with diffuse abnormality. And here, looking at the actual values, again, extracellular volume greater than 30% is considered abnormal. We can see that there are significant abnormalities in this particular case. So, this was pretty much just kind of a summary of the changes that we see. And, I think what's most important, again, as MRI becomes more and more useful in the setting of evaluating cardiomyopathies, I think it's always important to kind of have a unified approach. We understand the underlying pathology of the type of myocyte injury. We look for specific imaging parameters, features that help us prove that there is actual underlying abnormality. And from that, we make the correlation to determine what the specific etiology is. So again, tissue characteristic gives us insight into the mechanisms of fibrosis. We want to determine whether the disease is focal or diffuse. And certainly with that, depending upon the type of injury and the distribution of injury, gives us a clearer idea of the type of abnormality that we're dealing with. And we know that there's a spectrum of changes with both late enhancement and other parameters, including extracellular volume, T1 and T2, that help us clue in on the underlying diagnosis. So with that, I know that was a lot, and I certainly want to leave the floor open for questions. So thank you all for your attention, and please feel free to ask questions.
Thank you so much, Dr. Jeudy, for the great and very informative talk. You have discussed from the pathology till the imaging patterns. That was very great, and then the slides was very beautiful in illustration, and the cases were beautiful as well. So just to jump into the pathological questions, I would like to ask about the image quality. For example, in Mongolia, we are just at the beginning stage of introducing cardiac MRI, so we need to make sure the images are obtained correctly. So in general, in short words, how do you evaluate the image quality? Thank you.
Yeah, absolutely. I mean, image quality is probably the number one thing that we worry about. To make the diagnosis, you have to see the diagnosis. Probably the first thing is your technologist. technologists, need to be trained in cardiac MRI, as opposed to imaging, let's say, the musculoskeletal or the brain, which stays still. The heart is always moving, and with that, it brings a lot of challenges. So you want to make sure you have a good MRI with the appropriate cardiac sequences, and you want the techs to have good experience in being able. Even when we get new magnets, we spend maybe a good week making sure that the techs are trained well. We have normal volunteers so that we can make sure the techs get experience. And when you take the time up front to make sure the techs are good, then that quality gets better. Again, because of, patients may have arrhythmias, patients may have other issues. So also being with the patient, letting them know what to expect, also is very helpful. But yes, it's a very big collaborative piece. I would say, probably more than anyone, the technologist is going to be the one who really helps bring the control and the quality to the studies.
Thanks for the answer. Another question from the technical aspect as well. So is there any difference between 1.5 Tesla and 3 Tesla in terms of obtaining the cardiac images?
Yeah, that's an excellent question. So for many years, that has been something that we've looked at. The standard is at 1.5. So moving at 3 Tesla for the heart, for the myocardium, there honestly are not many advantages that we see. Certainly we get more signal, but one of the challenges at 3 Tesla is that we also get certain artifacts that you need to correct, more so than at 1.5. So in many ways, people will stay at 1.5 for the heart, or again, you have to take a lot of time to make sure that you have a good protocol and that your techs are adequately trained to be able to image at 3 Tesla if that's something you choose. Now, interestingly enough, and this might be something we'll see over the next 5 years, there is a lot of interest at doing cardiac imaging at actually even lower field strengths. So moving from 1.5 to 1 or 0.5. And that'll be interesting to see, now that there are newer techniques, newer ways of doing the reconstruction of the images. So it's possible to do it at a lower field strength and still get good images. So it might be interesting to see what we have. And with that, potentially may bring down the cost of MRI. And with that, maybe also make it more widely available.
Yes, Bibi.
Dr. Nat, go ahead.
Yes, Dr. Jeudy, what do you see about this T1, T2 mapping in the next 5 years? Is going to be more useful? It's going to be more informative, or it will die out?
It's a very interesting question. I think that, as it is now, it's proven to be very useful. I think that, when we consider most of MR, we're just kind of saying, okay, well, I see it or I don't see it. Whereas using the parametric mapping, it's kind of like, it's our microscope. It allows us to see more fine detail, more subtle changes. Now, the problem is, okay, one, we can see with parametric mapping, we can see better. We can see more subtle changes. The question becomes, well, is it clinically significant? Now we can see the change, but is it going to change therapy? Is it going to change management? And I think it will in different scenarios. So, for instance, I think in the setting of like, let's say, patients who are on certain chemotherapy agents, there's a question of whether or not, if you can identify changes early, do you switch them from that chemotherapy to a different agent? So, it's going to be that. For the use of, let's say, myocardial infarction, probably not. For myocarditis can be very challenging. So, parametric mapping does have a role there. So I think it's going to help guide decisions, but it's not so much that or for instance, like in the setting of amyloidosis, again, you're going to see the other abnormalities as well. So it's going to help more in the abnormalities where you need to, when you're trying to decide, am I going to take this pathway or another pathway? So whether for therapy or for other things.
I see. At the moment, is there any like a diagnostic criteria of the myocardial disease that use T1, T2 mapping as a diagnostic criteria yet?
So probably the main one right now is formalized would be myocarditis.
Okay.
So for myocarditis, you want to see the combination of a T1 and T2 abnormality. And so the presence of an abnormality using parametric mapping is part of the criteria in myocarditis. Now, there are other, so again, with amyloidosis, there's also the idea that if you have elevated native T1 values, that is also a very strong sign for underlying amyloidosis. But aside from that, those are the only ones where they're kind of formal tools. In every other tools, it more kind of helps you make the diagnosis. And actually, probably the most important thing actually that you reminded me that I should say is that for the most part, because we're still learning about this, T1 and T2 mapping is still really considered more in the research realm. So it's not that we use it to make diagnosis. It's really more confirmatory, and still a lot of research is being done to see exactly how these parametric mapping techniques can help us.
Thank you, Dr. Jeudy.
Okay.
Okay, thank you, Dr. Jeudy. So we have one question from the audience. Do all parameters include late gadolinium enhancement, ECV map, T1, T2 mapping, T2 star mapping? Should all be done routinely in cardiac MRI, or should we make another view, or short axis is enough?
Yeah, that's a great question. So classically, the short axis is really good. So, kind of taking them all in turn. So late enhancement is really the primary tool that we use. And so for any, cardiomyopathy, we definitely get that. Now, the other techniques, the parametric mapping, so T1, T2 mapping, T2 star. T2 star, we definitely use in the setting of iron-related cardiomyopathies. The other ones, again, we do use as well. So for the purpose of cardiomyopathy, purpose of patients with heart failure, we do use it. But it doesn't make it the standard. The late enhancement is the one portion of that we always do. The tissue mapping, again, depends on what the story is. If it's someone who we don't know what's going on, we just want to take a look. All right, well, it might not be important. But if they're like, okay, we know this person, they're taking, this chemotherapy agent, and we're worried that, they might be developing cardiotoxicity, then that's definitely someone we want to use it. So, and also I think it's with good collaboration with your colleagues as well. Some cardiology colleagues, you'll say, oh, well, the ECV is abnormal. And they may say, what's that? In that situation, it may not be helpful. But certainly as you do more advanced cases, as you do research, all those different techniques become important. And then finally, with that, in order to do the parametric mapping, you need to have the tools to do the mapping. So, being to have, whether it's the vendor or other third-party tools to be able to do those measurements, that certainly becomes important as well.
BB, there is more questions. I'm sorry, BB.
Oh, sure. There's another one from audience, and it says, can we use native T1 value in both 3.5 and 3 Tesla MRI?
Yes, exactly. So, so remember, the T1 value that we are using is based on the relaxation of those, those protons in the magnet. And certainly at a higher field strength, those values are going to change. So yeah, the numbers, and I apologize if I didn't mention that before, those numbers are generally at 1.5 Tesla. At 3 Tesla, we usually have higher, so usually over 1200, some people would say 1250, would use that. Now, the other important thing to remember for parametric mapping, again, the field strength is important, but also there is heterogeneity with every magnet themselves. So what is always, what's recommended is that every site kind of develop their own normal values, meaning doing a few normal volunteers and figuring out what the normal values are for your particular magnet. Now, there is some research in trying to kind of standardize the values so that you can do quantitation regardless of the magnet. But for now, again, it's still recommended that everyone do the specific kind of volunteers on their own and develop your own standard reference for your specific magnet.
Thanks for the.
Yes, Dr. Jeudy, the SCMI has a talk about the native T1 in the local, like you should do your own volunteer, depends on the parameter that you may need only 30 or you may need like 20 or 50, depends on the how fine it is you want to characterize the patient. Suppose if I'm doing that at Wake Forest and I'm using the Avanto 1.5 Tesla Siemens and so how big is the population? Is the population in Winston-Salem or is the population in North Carolina? So what is the standard of that, of the number that we get from the experiment that we can use with population? It's like
so
the whole.
Yeah, I mean, I think, the reality is, if you look at different centers, you'll find that the numbers vary quite a bit. So there isn't really a standard. Certainly, if you can do 50 patients, I think that that provides a lot of strong evidence. And then I think also when you look at the standard values, the standard ranges that have been put in the literature based on large populations, I think that's also a good reference to go by. But mainly, I think the primary thing is, one is to have good technique. Again, your techs are very comfortable in acquiring the sequences, that you can acquire them and do the quantification. Doing the quantification, depending upon the tool, also needs certain parameters to be in place, and that that your results are reliable, meaning that in some cases you might want to do the same patient more than once to make sure that your numbers are repeatable.
Okay. Thank you.
No problem.
Oh, it's so happy to see that our attendees are very active today. And there's another question. And thank you so much for the nice lecture. And the question is that, can we see on the extracellular, can we see the extra intercellular edema, and should you describe it on the report?
So again, an interesting question. So obviously I'm going to give you my opinion, and but before that, remember that parametric mapping technically is still in the research type of spectrum. So whenever you're putting out a value, you're saying that that value has a specific meaning and should be followed for a specific reason. So now that being said, the people that you are working with, so if there's a cardiologist that is working with me and wants those numbers to track, then I will give it. But usually I will just say whether or not the numbers are abnormal. So I would say, T1 and T2 parametric mapping was performed and is within normal limits. Or I'll say, there is evidence of increased relaxation on T1, on native T1 techniques and expansion of extracellular volume. I don't necessarily include the values, but certainly, again, depending upon the context and who I'm sharing it with, then maybe I will. But I always have the values. So if that person comes back, I want to check it against what we measured before. So I always maintain the values, but I may not necessarily put it in my report. And you'll find that, different people may have different opinions about that. But again, I think the other reality is that as physicians, there's a tendency to chase numbers. And I try not to encourage that, particularly when things can be, when you're not quite sure where things actually fall.
All right. So if there is no question from the attendees, I would like to ask this. The native T1, suppose is it normal? Do we need to calculate ECV?
Technically, no. I mean,
Yes.
if it's normal, it's normal.
Yes.
I mean, it would be very unusual for there to be a situation where your ECV would be abnormal.
Yes, Dr. Jeudy. And what about those color? It's always standard color of T1, T2 mapping. Is it like the company decide the color for us, and it's just the company, just the software? Is that correct?
Exactly.
Nothing,
It
nothing
varies.
hiding.
No.
Okay.
I mean, obviously, you want to look at the scale to know what the colors mean, but the actual, it varies per vendor and different, whether it's third party, the magnet vendors, it's all different. Whichever one has the prettier color, I guess.
Yes. What about these amyloid? Or we always say like, okay, this is the light chain type, and this is ATTR type, and the enhancement will be different. And in the cardiac MR, I normally always see like transmural, and the transmural is supposed to be, if I am right, the transmural is supposed to be the ATTR type, and the subendocardial enhancement is a light chain type. And my question is, the incidence of light chain is more than the congenital one. Oh,
yeah, I'm here. I don't know why my face is frozen. It's not that your question was that tough. So as far as the there we go. So as far as the and I'm sorry, maybe I missed part of the question. So yes, they definitely present with different may prevent manifestations. So obviously the like the AL subtype versus the ATTR, may present with ATTR may be more subendocardial, AL may be more diffuse. So I mean, we see kind of overlapping subtypes from time to time. But I think in either case, what we typically see is an infiltrative process, thickening of the myocardium, diastolic dysfunction, as well as the enhancement.
Yes, those patients, do they need to go further to do like a PET CT or do further investigation because these two has different treatment? Is that correct?
Yeah, so there's a lot of interest in getting pyrophosphate imaging with PET. So I think that is that's an interesting situation. So, and we've certainly seen that. Interestingly enough, there are some centers that have a combination of PET and MR, but I have not seen a lot of people doing a combined study for those patients. So yeah, and I think again, this is where this technique continues to evolve, and finding the right combination, I think we'll see over time.
Thank you, Dr. Jeudy.
No problem.
Dr. Bold, do you have anything to add to?
Yeah, I would like to ask just one question, but it's not really related to today's talk. It's
okay.
Okay, thanks. And Dr. Jeudy, you work as a professor of radiology. At the same time, you serve as a vice chair of the clinical informatics, right? So
yes.
How AI and clinical informatics are being used in the field of cardiac MRI and cardiac imaging?
Actually, it's actually very exciting. A lot of things are happening. On some level, AI, or I should say cardiac MR, has always had a very big role with AI, especially, early on looking at trying to quantify ventricular volumes and calculate EF and doing it automatically. So there's been a lot of expansion with that. Probably some of the interesting things now include one, trying to characterize not just the volume of enhancement, but looking for, again, texture analysis to see if there are more subtle ways of looking for underlying myocardium, looking at other functional evaluations. So again, diastolic dysfunction, valvular function, with that. And then from the technical standpoint, how do we, like we said, moving from 1.5 to 0.5 Tesla, there's going to be a lot of reconstruction techniques in making the images better, ways of making the studies faster. So, using, half, quarter Fourier techniques to be able to do the reconstructed images. So, what's fascinating is that it's coming from every aspect, from the reporting, from the quantification, quantitative analysis, to even the acquisition of the images. And I think that there's still much more to go. So, I think there's a tremendous amount in AI, and, hopefully it will make all of our work, not only that much more interesting, but hopefully that much more easier too. So, okay, one more question, I think.
Yeah. Hey, Dr. Jeudy. Hi, this is JP. I'm Dr. Nat's colleague from Wake Forest, Winston-Salem. How are you doing?
Good.
I greatly appreciate you coming and giving this lecture. Thank you so much. One quick and last question, and it's very short, I promise. Just in the era of the pandemic with COVID, we have seen a couple of COVID-19 myocarditis. Any thoughts on that? And if you have seen any of those cases, I know the imaging modality of choice is cardiac MR. Any special protocols, or is it just regular thing which we do? Thank you.
Yeah, no, that's an excellent question. And, interesting enough, I mean, we've seen a lot of myocarditis. Specifically, we've done we're actually doing research studies on young athletes, so who have gotten COVID and myocarditis. We've seen, obviously, myocarditis in both the vaccinated and unvaccinated, certainly most severe in the unvaccinated. Whereas in the vaccinated tends to be much mild and usually, just kind of a brief symptoms and then, discharge to home. So yeah, we've definitely seen it. The protocol really is no different from our typical myocarditis. So, we do parametric mapping on all cases. Obviously, we do enhancement, and we look for edema. So I think some of the other things that are interesting to also keep in mind, although not part of the primary diagnosis, presence of pericardial effusion is considered one of the things to keep in mind. Also, we haven't seen any cases of this, but if there is, I take that back. We've seen a couple of cases where patients who, one who did have myocarditis and one who didn't, but did have pulmonary involvement. So again, for every cardiac study, you also want to evaluate for non-cardiac, things as well. So, but after that, yeah, I would say just, the primary myocarditis protocol is appropriate. Your clinicians are going to be more likely to order them when in the situation where they're worried about underlying myocarditis. So I think it's really more about our awareness, and we've certainly seen a lot more of that.
Thank you so much.
Oh, no problem.
Thank you, Dr. Jeudy, for accepting our invitation and request to give this great lecture. I hope it benefited a lot of people, and then they will use the knowledge and information gained from her to advance MRI settings in their native countries. So thanks to the participants, organizers, and especially to our guest speaker, and then it was nice to meeting you through this webinar and seeing all of the participants. And then thank you so much. And we are ending the session for now. And do we have anything to add, Dr. Nath?
I do not have anything to add to, but I just feel very grateful that Dr. Jeudy accepted to be our guest speaker. He is so sweet. He was my former attending. He's always as sweet as he is all the time, all these years.
Stop.
Thank you.
No problem, no problem. It's a pleasure to be here with all of you. Thank you so much.
Thank you, everyone.
Okay. Take care.